Hey everyone. I'm sorry, I just have a bit of a cold at the moment. This is a topic that a lot of people suggested that I should do a video on in the last time we talked, and I think it's a really important topic as well. Antibiotics are some of the most widely prescribed drugs. Whatever doctor you're going to be when you graduate, you're going to be prescribing a lot of antibiotics. And I think it's really important to know about antibiotics and antibiotic coverage well, because antibiotic resistance is going to be one of the biggest challenges we're going to face as a medical workforce in our generation. So, really important topic. I'm glad we're going to do a video on it. Which takes me to the bad news is that I can't fit everything into one video. So I'm actually going to split this into 3 videos. The good news is that makes each of the videos shorter and more digestible, I hope. But 3 parts. The first part is going to focus on a classification for the microbes or bacteria and get started on a few of the antibiotics. The second video is going to finish off the rest of the antibiotics. And the third one, which is super high yield, will go through the main infections that we're likely to see in clinical practice and in your biomed exam, and which antibiotics are required to cover for the main causative organisms in those infections. So I hope you enjoy the videos. As always, look forward to your feedback. Please send it to me by message, on comments. Happy to talk to you. See you. Right. So I think this is an appropriate place to start this topic. That's the discussion, that's establishing a classification system for the microbial agents that your antibiotics will be targeting. I've often made the mistake when I've tried to learn this topic in exclusively looking at the antibiotics, and that's almost looking like half the picture. It's like fighting a war, but not trying to understand your enemy. I think it's so important to get an idea of the bacteria you're fighting, because that's the way you're going to understand the relevance of the coverages of your different antibiotics. So I want to start at the very basics. I want to start with our division of bacteria. And as you all know, this will be a bit of revision, but I do want to establish this. Our division of bacteria is really founded on the bacteriological test called the Gram stain. And what the Gram stain does is it exploits the difference that exists in the structure of the bacterial wall. And as you'll probably recall, gram-positive bacteria, their bacterial wall consists of a thick peptidoglycan layer. In contrast, gram-negative bacteria has a very thin peptidoglycan layer, and their walls are completed by an outer membrane, right? So this is the structural difference that the Gram stain exploits. Now, I think it's very important to know how the Gram stain works. Not because it's going to be important clinically. All you really need to understand clinically is which bacteria are gram-positive, which bacteria are gram-negative. But because in the biomedical science exam, they have asked you to describe a Gram stain before. Some of you may be doing it for your investigation of choice. So let's talk about it, because once we talk about it, you'll never forget it. And this diagram, I think, is quite good. It represents the gram-positive bacteria by cocci, so circles, you can see them here, and the gram-negative bacteria by these rods that you can see here. So the first step of the Gram stain is the application of crystal violet, and what that is essentially a purple dye. So on your slide, which on it is the sample you've collected from the patient. It could be a swab taken from a wound, it could be a sputum culture, it could be urine which you've put on a slide, it could be a high vaginal swab. You've essentially got bacteria there and you want to stain them. So you stain them with crystal violet, right? And everything, the gram-positive, the gram-negative bacteria that are potentially on that slide, they stain purple. The next thing you do is you apply iodine. Now, why do you apply iodine? Iodine is actually put in to form a complex between the crystal violet and the iodine, making a large molecule that is bigger than the original crystal violet. This molecule is now also insoluble in water. The third step involves adding an alcohol wash, right? And this works differently depending on what sort of bacteria you have in your on your slide. Now, if it's a gram-positive bacteria, a bacteria that will eventually stain gram-positive, i.e. has, let's call it a thick peptidoglycan layer bacteria, what will happen, what the effect the alcohol has, it actually dehydrates the peptidoglycan layer. And what that does is it traps the crystal violet iodine molecule inside the bacteria, because the cell wall, the bacterial wall is now tighter and difficult to permeate. So that's why number 3 shows all the gram-positive bacteria still staining purple, right? Now, in the bacteria with thin peptidoglycan layers, the bacteria that will eventually be gram-negative bacteria, all the alcohol does is washes out the crystal violet iodine molecule. It just washes out, right? And that happens because the peptidoglycan layer is very thin. There's no ability for the alcohol to dehydrate it to that extent. And yep, it just can't keep that solution inside, and so that washes out. The last step is the application of a counterstain. And what the counterstain, it's a red colored stain. Now, for the gram-positive bacteria, which are already stained with crystal violet iodine, the counterstain is actually lighter in color than the crystal violet, so it does not disrupt the colorization. So that's why these still remain purple. But for the empty gram-negative bacteria, this counterstain actually just stains them pink, right? And so this is how we originally differentiated between the two large groups of bacteria, the gram-positive ones and the gram-negative ones. So this is what you need to have in the back of your mind when you think about bacterial categorization. And I understand that this can be a very intimidating list to look at. Believe me, I can. Let me pick a color that'll stand out here. Right, so there are a few tricks to understanding this table. The first is that if you're thinking of a bacteria, the most likely bacteria you're thinking of is either a gram-positive cocci or a gram-negative rod. There are a lot fewer gram-negative cocci and gram-positive rods, right? So that's the first thing. That's the way I like to think about it. The next thing I like to do is really think about the prime suspects in the majority of the infections that you're going to encounter clinically and in the biomedical exam. And those are the ones really worth remembering on where they stood. Now, staph and strep are huge in lots of infections, as you know. And it's very important to know, because of that, it's not very hard to remember that they're cocci, because it's in the name, that they're gram-positive cocci, right? Now, it's good to know Neisseria, because there's a meningitis case, and it's your prime meningitis suspect, the Neisseria meningitis bacteria. It's also good to know Moraxera catarrhalis, which is a suspect for pneumonia. Bacillus doesn't really come up Clostridium doesn't come up. Corynebacterium doesn't really come up. Listeria, however, does again come up in the meningitis case as one of the suspects. So good to remember that. The gram-negative rods, it's a huge category. So you should remember a few of these, particularly Bordetella pertussis. There is a pertussis pass question, I believe. Haemophilus influenza is one of your pneumonia candidates. The Enterobacteria species come up all over the place, so it's good to remember these. Pseudomonas is important to remember. You know, Campylobacter is, sorry for the typo, is one of your hemorrhagic gastrointestinal potential infections, and Helicobacter is your bacteria associated with gastric ulcers and gastritis, right? And yep. So I know I've almost asterisked every one of these, and we're going to be talking a lot more about these suspects in the third part of the lecture, but don't stress too much about this at this stage. You can come back to look at it once we sort of look at the main clinical infections, and then it'll make a lot more sense. Equally, I made it seem like bacteria either stain gram positive or negative. That's not exactly the case. There are non-gram staining microbials. They're the atypical infections. And the mnemonic for these is these microbials may lack real color. So Treponema, Mycoplasma, Mycobacteria, these microbials may lack real color. Right? So just keep that in mind as well. As I said, some of these come up in the cases. Mycoplasma definitely does. Mycobacteria, you know, from tuberculosis, always worth keeping in mind. And the rest really don't really come up in the clinical infections you're going to be seeing in the biomedical science exam, but just good to know a lot of them, and then you can work out the rest by exclusion. So this is another annoying looking chart that you've probably seen before. And let me explain the clinical relevance of this and why, again, I'm bringing it up. Again, clinically, you're probably going to have your main suspects when you have a particular infection. For example, down the bottom here, we've got Staph aureus, common in skin and soft tissue infections, versus a strep pneumonia, which is more common in a pulmonary infection, for example. But you know, there are times, example, for a pneumonia, when either of these two agents can be the causative organism. So we've got to have laboratory methods of being able to see after microscopy what bacteria actually was the causative agent. That way we can best tailor our antibiotics, right? So the microscopy gets you to here. The gram stain microscopy, after that step, you just know that you have a gram-positive cocci. It could be staph, it could be strep. So we do a few other tests to actually work out which bacteria it exactly is. The first one is an enzymatic test called catalase. And what we're doing is actually searching whether the bacteria has the virulence factor of catalase. Catalase is an enzyme that actually breaks down hydrogen peroxide, and that's the reactive oxygen species that's released by neutrophils in an attempt to phagocytose bacteria. So bacteria that have catalase are able to resist these reactive oxygen species, and that gives them a survival advantage. So if a bacteria is catalase positive after being a gram-positive cocci, it is Staphylococcus, right? And if it's catalase negative after being gram-positive cocci, it is Streptococcus. Make sense? Right? So say you've got a catalase positive, gram-positive cocci. The next step is to do a coagulase test. Now, coagulase is testing for the enzyme coagulase. And coagulase, what that does is it can coagulate the blood directly around the bacteria. And what that allows the bacteria to do is to resist the infiltration with white blood cells, which normally come through the blood. And again, that's another virulence factor. It's a survival advantage. And Staph aureus is coagulase positive, whereas the coagulase negative Staphylococci species are Staph epidermidis and Staph saprophyticus. Now, these do come up later in the infective endocarditis case and in the urinary tract infection case, respectively. So, again, good to know these bacteria and good to know the way we differentiate them clinically, right? Now, on the other side are these gram-positive cocci that are catalase negative, and these are all our strep species. Again, that's a typo. That should say streptococcus. Now, the way we define the differences between our strep species isn't through an easy enzymatic test. We actually have to culture them, and we look at the hemolytic pattern, the way they hemolyze blood cells, the red blood cells on the culture plate. Now, the clear hemolytic pattern, or the beta hemolytic streptococcal species, are the Strep pyogenes and Strep agalacticae, right? The gamma hemolytic are the Enterococcus streptococcal species, and these have actually, it's become a point of debate whether these are actually still strep species. They're just, some count them as a third category of gram-positive cocci, apart from staph, strep, and they give Enterococcus their own category. Doesn't really make a difference. You can think of them either way. And lastly, it's the alpha hemolytic, or the green hemolysis pattern, and these are your Strep pneumoniae and your Strep viridans. So now that we've talked about a general system for categorizing bacteria, we can start talking about our antibiotics. And the way I break down antibiotics, there's only 4 main classes you really have to know about, and you can categorize everything to these 4 main classes. They're the antibiotics that inhibit cell wall synthesis, antibiotics that inhibit the translational products of bacteria, antibiotics that inhibit nucleic acid synthesis, and an unclassified group of antibiotics. Let's start with the cell wall synthesis inhibitors. So these are antibiotics that inhibit the ability for bacteria to construct a cell wall for themselves. And they include 2 main groups. One is the lactam antibiotics, and 2 is vancomycin. Now, the lactam antibiotics, they're called lactam antibiotics because they have a square beta-lactam ring. Now, the square beta-lactam ring is an important structure to consider because it's actually the weak point of these antibiotics, because bacteria have developed an enzyme called beta-lactamase. This enzyme is capable of cleaving the square beta-lactam ring, and hence a lot of microbes have developed resistance to these antibiotics. But they include penicillins, cephalosporins, Imipenem, Meropenem, and Aztreonam. Now, don't worry if you haven't learned too much about these antibiotics as of yet. We'll be covering them all, and it's not as difficult as it sounds. And then we've got our second group of cell wall synthesis inhibitors, and that's vancomycin, right? So let's start with the penicillins and cephalosporins. Now, the easiest part about this is that the mechanism of action of all the cell wall synthesis inhibitors, at least all the lactam antibiotics, is the same. It's 3 steps. These antibiotics bind to the penicillin binding protein. They inhibit the transpeptidation and inhibit cross-linking of the peptidoglycan layer of the bacterial wall. Does that make sense? It's the same for all the lactam antibiotics. 3 steps, not very hard to remember. Now, equally important is the mechanism that bacteria have of resisting these antibiotics. The first one we already discussed, beta-lactamase, that cleaves the square beta-lactam ring. The second change that bacteria have undergone to become resistant to these antibiotics is actually structurally changing that penicillin binding protein.
And this is actually the mechanism which MRSA has employed. So that's methicillin-resistant Staph aureus. That bacteria has actually, it has a beta-lactamase, but its next step up was to change the penicillin binding protein, making it hard for any of the penicillins, the cephalosporins, the imipenem, the meropenem, the Aztreonams to bind to it. Therefore, you must use the other cell wall synthesis inhibitor. You use vancomycin. And the last mechanism bacteria have come up with to resist these antibiotics is changing their porin structure. Now, this is actually relevant for gram-negative bacteria. If you recall, these bacteria have an outer cell wall outside its thin peptidoglycan layer, so they've got an outer cell wall, thin peptidoglycan layer, and this outer cell wall has porins. And antibiotics were designed to fit in these porin channels to attack the bacterial wall. Unfortunately, these bacteria have developed changes in porin structures that stop these antibiotics from passing through to attack the membrane. Okay? So let's start by talking about penicillins and the 4 generations that you need to know about. Now, generation 1 today is a narrow spectrum of penicillins, and it's beta-lactamase sensitive, right? So it's got a narrow spectrum of action primarily because of its sensitivity to beta-lactamase. And examples of these drugs include penicillin G, penicillin V, and they still work when you're sure that the infection is a streptococcal infection. So strep pyogenes, strep pneumonia, these drugs still work against them. You can also use them for Treponema pallidum, which is the syphilis infection. And I guess to give you a clinical example of where I see penicillins being used, when I was in the Northern Territory and we had Indigenous children coming to our clinic with sore throats, we were concerned about strep pyogenes and the post-streptococcal complications that you can get, i.e. glomerulonephritis and rheumatic fever, rheumatic heart disease. These children were given penicillin, right? Because that's the main causative organism you're worried about in strep throat, right? Strep pyogenes. The next generation penicillins, they were developed to be beta-lactamase resistant, right? So, but the downside of them was that they are very narrow spectrum. So let's talk about Staph aureus. So Staph aureus is one of those bacteria that develop beta-lactamase. So the first generation obviously don't work. The second generation, because they're beta-lactamase resistant, work. And the Staph aureus that they work on are called methicillin sensitive Staph aureus, or MSSA. Examples of methicillins that work against Staph aureus include flucloxacillin, dicloxacillin, right? And they are used for MSSA. But over time, Staph aureus has evolved again. So the first evolution was developing the beta-lactamase. The second evolution was changing its penicillin binding protein, as we discussed, right? And that has produced a new species called MRSA. Okay, I hope that makes it clear. Right, so I've just cleared my screen to make it a bit clearer. Now, the third generation of penicillins are the broad spectrum generation of penicillins. They're still beta-lactamase sensitive, mind you, so not like the last generation. And they include drugs such as amoxicillin, ampicillin. Amoxicillin is the oral form, ampicillin is the IV form. But how these penicillins achieved more of a broad spectrum is actually changing their solubility. And that changed solubility actually allowed them to enter porin channels, which we talked about. and that gave them action against gram-negative bacteria. So they are active against gram-positive cocci, though of course not against staph. They are active against gram-positive rods, right? But they're also importantly active against gram-negative rods. So a good mnemonic to help you remember which bacteria this has an action on is helps kill enterococci. What that stands for is Haemophilus influenza, E. coli, Listeria, Proteus, Salmonella, Shigella, and enterococci. Right? So just having a look at these, we can see that this is a gram-negative rod, this is a gram-negative rod, this is a gram-positive rod, this is a gram-negative rod, this is a gram-negative rod, this is a gram-negative rod, and this is a gram-positive cocci, right? So it really has a broad spectrum of action, very commonly prescribed drug. And then the last generation of penicillins, these are your extended spectrum. They have anti-pseudomonal activity, but are still beta-lactamase sensitive. So these include ticacillin, piperacillin, and they extend to gram-negative bacteria such as Pseudomonas. Right? So I hope that breaks down the generations of penicillin for you, and that makes it pretty clear. Now, there's some important considerations that you have to take with penicillins. As we mentioned, penicillin 3, generation 3 and 4 are beta-lactamase sensitive, right? So they're actually used with beta-lactamase inhibitors, so prodrugs that inhibit the beta-lactamase enzyme. As you know, amoxicillin is often given with clavulanic acid in the drug called Augmentin. Similarly, piperacillin is often given with a beta-lactamase inhibitor called tazobactam, and together they form tazocin, again a very commonly prescribed drug. The other thing that happens is that penicillins often are prescribed with aminoglycosides, which we're going to talk about in a second, for enterococcal and pseudomonal infections. And we'll talk about why that's the case. But essentially, it's because penicillins are able to work on the cell wall, on the bacterial wall, and aminoglycosides are able to inhibit the translation of bacterial proteins. So they work with different mechanism of actions, and they stop the bacteria in two different ways. The pharmacokinetics of penicillins, important to work out, is that they are eliminated via tubular secretion. So in people with renal dysfunction, you must adjust the dose. Now, the side effects of penicillins, you've got to know about the hypersensitivity response. That's the big one. The potential for hypersensitivity and anaphylaxis is your biggest concern. And if one person is allergic to a penicillin, do not use another generation of a penicillin or even a cephalosporin, because 5 to 10% of people are cross-allergenic to cephalosporins as well. So if you can, try to avoid cephalosporins in these patients. Or if you absolutely have to give a cephalosporin, you have to watch them very closely. The second side effect of penicillin is gastrointestinal distress, and that's thought to be because of a killing of endogenous flora in the gut, and that can give you a diarrhea. But if it's particularly severe, you can actually develop an opportunistic infection with Clostridium difficile, and that causes not a Pseudomonas colitis, sorry for my misspelling, that causes a pseudomembranous colitis, which will require treatment with metronidazole. Right? So the side effect can just be some diarrhea, it can be some gastrointestinal distress. It does not always have to be a superinfection with Clostridium difficile, but you're particularly worried if you've got bad diarrhea that's persistent after a course of a drug like ampicillin. Which brings us on to our next class of drugs, the cephalosporins. Cephalosporins come in four main generations, and what I was taught by a few clinicians when I was a bit younger was that as you go down the generations, your gram-positive action gets worse, but your gram-negative action gets better. Now, I initially took this word to be true until a few people I'd met who were particularly interested in infectious disease, including a couple of infectious disease doctors, said that this is just a blanket statement and is not exactly true. So I'd be aware that some people talk about this rule, but have my reservations on how technically accurate such a broad blanket statement actually is. And perhaps it's better if we actually just go look at the individual coverages. So the first generation of cephalosporins have very good gram-positive activity and some gram-negative activity. So Proteus, E. coli, Klebsiella, you can remember those gram-negative organisms by the acronym PEC, and they have a long half-life, and because of this, because particularly of their activity against staph, strep, they're very good for surgical prophylaxis. Yep. They do not have CNS penetration, which is where the second generation of cephalosporins come in. The second generation of cephalosporins aren't used very much in hospital anymore, actually, because the third generation is so good. It does everything the second generation does, but a little bit better. But let's talk about the second generation first. Again, very good activity against gram-positive organisms and an expanded range of gram-negative organisms. So Haemophilus influenza, Enterobacter, Neisseria, Serratia, and the ones above. So you can call this group the HENPEX group. Yep, will make your life a bit easier. So they've improved because they have better gram-negative cover and they're actually able to cross the blood-brain barrier. Right? So you can use them for things such as meningitis, particularly when you've got Neisseria as your causative organism, and things like strep pneumonia. But the third generation was so good because they improved their spectrum and also had the same ability to penetrate the blood-brain barrier. And they're really, with these ones, they're so broad spectrum that you just have to remember the bugs that they don't cover. And that can be covered by LAME. So Listeria, which you know responds well to amoxicillin. The atypical bacteria, the ones that don't gram stain, and they actually respond well to protein synthesis inhibitors such as the macrolides and the tetracyclines. This doesn't cover against MRSA, which responds to vancomycin, as we know, and enterococci, which responds well to ampicillin. So they are really broad spectrum drugs, and that's why they're used in the empirical management of infections such as meningitis and often sepsis. So yeah, very, very highly used drug today, the third generation of cephalosporins. The fourth generation of cephalosporins is a very broad spectrum drug. They can only be given IV. They're resistant to beta-lactamase, but they're mainly used against Pseudomonas. Yep. Okay, great. So the considerations we have to have with cephalosporins is like the penicillins, they're cleared through the renals, the kidneys, and you have to modify your doses in patients with renal dysfunction. Side effects are similar. You have a hypersensitivity response, and if you have a hypersensitivity response, then your options for gram-positive infections include macrolides, which we're going to talk about, and for gram-negative infections, you've got a couple of choices. You've got Aztreonam, and you've also got something like your aminoglycosides, but we're going to talk a bit more about that later. They can also cause gastrointestinal distress with the potential for Clostridium difficile superinfection. And yeah, I just wanted to add one thing about the hypersensitivity. And it's the reason why you get hypersensitivity responses with both penicillin and cephalosporins. It's because of both these sets of drugs in the molecule include sulfur, and sulfur is the reason for this hypersensitivity prediculation, if that makes sense. right? And so that takes us to Imipenem and Meropenem. Now, these are actually drugs that are, again, the mechanism of action, as we said, of all lactam antibiotics is the same. But these are actually resistant to beta lactamases. So these are very powerful drugs. And they have a very broad spectrum of gram-positive cocci, gram-negative rods, except MRSA, which you can use vancomycin in, right? And these are in-hospital agents that are reserved for empiric use in severe life-threatening conditions and infections. So unless you've been around, spent a lot of time in ICU, you probably haven't seen much of this drug being used. Some important things about pharmacokinetics. Look, this drug probably isn't going to come up in your biomedical exam, but it's good to know that imipenem is actually given with a drug called cilastatin. That's a renal dehydropeptidase inhibitor. And what that essentially allows that to do for imipenem is extend its half-life. Again, imipenem, meropenem, both renally eliminated. You have to adjust dose in renal dysfunction. The side effects, GI distress, hypersensitivity, but this hypersensitivity response is characterized by an elevated temperature or a drug fever, and also has CNS effects such as seizures. Okay, so not something you just pull out of a hat for an infection presenting to you, but it is used when you have an infection where you're not really sure of the source, and it is used empirically sometimes. Aztreonam, again, so mechanism of action, it's like penicillin and cephalosporin and imipenem, meropenem. This one is also resistant to beta lactamase, and its use, I have to admit, I haven't seen it too much being used, but it's an intravenous drug active against gram-negative rods, and because it's got no cross-allergenicity with penicillins and cephalosporins, if you're giving a penicillin like amoxicillin or a cephalosporin such as ceftriaxone to get some gram-negative cover, it's very good at supplementing that without giving one of these drugs that might cause an allergic reaction. Again, I have to admit I haven't seen it too much being used. I normally have seen a lot more aminoglycosides used, but this is what the textbooks say. Which takes us to our last cell wall synthesis inhibitor, which is not a beta-lactam. So this one actually has a different mechanism of action. This is vancomycin. So its mechanism of action involves binding at the D-alanine muramyl pentapeptide. That's an absolute mouthful. You just have to remember that. I have no idea what that is, but it is just one of those things you have to learn. And it sterically inhibits transglycosylation, which is essentially, in English, an elongation of the peptidoglycan cell wall. And this one doesn't interfere with penicillin binding protein, which is why the fact that the methicillin-sensitive Staph aureus changing its penicillin binding protein doesn't affect this drug. Right? So you just have to remember two steps for this one. There's a cell wall inhibitor, and this is what it's a bacterial wall inhibitor, synthesis inhibitor, and this is how it does it. I would just recommend learning it, not worrying too much about exactly what all of these things are. But their spectrum is MRSA, Enterococci, and Clostridium difficile. Right? But resistance VRSA, very concerning. Vancomycin-resistant enterococci also emerging. You'll often see the sign outside patients' rooms in hospitals. Be very careful going in without washing your hands or with protective equipment. And the way the resistance in VRE works is, again, the receptor D-alanine muramyl pentapeptide has changed such that the D-alanine is replaced by D-lactate. That's a fun fact you can remember if you want to. Again, it's probably not going to come up in your biomedical science exam, but I think it is important, given drug resistance is such a prevalent issue. We should know a little bit about it. Pharmacokinetics, it's used intravenously and can be used orally in pseudomembranous colitis. It enters most tissues but doesn't have CNS penetration. It's eliminated by renal filtration and has a longer half-life. Has a long half-life. Now, the side effects, these are classic, so you can get asked about this quite often. It's got a very characteristic hypersensitivity response, which includes a strong vasodilatory component secondary to the release of histamine, and that's called the red man syndrome. Also ototoxic and nephrotoxic, and particularly when used in combination with other drugs.